Hi everyone, excuse me. Hi everyone, and thank you for joining today's webinar, Increasing Access to Mental and Behavioral Healthcare in New Mexico. I'm pleased to introduce today's speakers, Alex Bachert, a Clinic Partnerships Manager at Genoa Healthcare Telepsychiatry, and Dr. Neil Bowen, Chief Mental Health Officer at Hidalgo Medical Services in Silver City, New Mexico. During today's presentation, Alex and Dr. Bowen will walk us through the following topics: the landscape of mental and behavioral health in New Mexico, the benefits of telepsychiatry for clinics, clients, and providers, and Hidalgo Medical Services telepsychiatry experience with Genoa Healthcare. Before we begin our discussion, I'd like to address a few housekeeping items. We've muted all attendees to avoid any potential background noise and to ensure a quality recording. The webinar will be recorded and shared via email to all participants early next week. We've allotted 10 minutes at the end of the presentation for Q&A. Please feel free to submit questions throughout the next hour, and we will do our best to address them at the end of the session. If we don't get to your question during today's webinar, we'll be sure to follow up afterward. Now, I'd like to turn the presentation over to Alex.
Thank you for the intro, Lauren, and thanks again to everyone for attending today's session. As we know, the country is facing a shortage of psychiatric resources, plus an increased demand for mental health care. Not the best combination for meeting mental and behavioral health needs. According to a report by the National Council on Behavioral Health, 77% of counties in the US are underserved, and 55% of states have a serious shortage of child and adolescent psychiatry. Because of this, about 45% of patients with serious and persistent mental illness go untreated. We see this shortage the most in rural regions, many urban neighborhoods, and community mental health centers that often treat the most severe mental illnesses. Many of these fall in health professional shortage areas. To date, there are 72 mental health professional shortage areas in New Mexico. In 2014, there were nearly 46,000 psychiatrists in the US, which averaged to 13.5 psychiatrists per 100,000 people. The number varied by state, with 4.5 psychiatrists per 100,000 people in Idaho, and 43.2 in Washington, D.C. The number of psychiatrists in New Mexico was 11.8 per 100,000 people. As a whole, the field of child and adolescent psychiatry is much smaller than general psychiatry. There are just 8,000 child psychiatrists nationally. In 2014, the national average was 10.4 child psychiatrists per 100,000 people, which is right in line with New Mexico's average. So why telepsychiatry? How can this help with the national shortage? Over the past 10 years, telepsychiatry has grown from a novel idea used mostly in academic and experimental settings to an increasingly mainstream way to provide psychiatric care. Over 1 million appointments have been delivered nationwide, and the industry is growing by more than 20% each year. With this growth, we've seen a shift in the way that organizations view telepsychiatry. More and more CMHCs are seeing it as a valuable resource to increase access to care that might not otherwise be available. Based on Genoa's experience over the past 7 years, we have identified 4 salient benefits of telepsychiatry. The first is that it helps organizations to find providers that are the right clinical and cultural fit. It broadens the provider pool beyond an organization's zip code and allows you to connect with providers that align on prescribing philosophy, cultural values, and whatever certifications you require. The second benefit is that by bringing care right to the patient's location, we see a reduction in delays of care, as well as trips to the ER, which ultimately lead to better outcomes and help manage costs. According to a study published by the VA, which has been doing telehealth for 2 decades, those that receive visits with telepsychiatry saw a 25% reduction in bed days and a 19% decrease in hospital admissions. The third benefit is the ability to operate sustainable psychiatry. We know that telepsychiatry is different than in-person psychiatry, and we're using that difference to our advantage. Telepsychiatry allows organizations to hone in on best practices and workflows to improve continuity of care and follow-up rates. It also fosters an integrated approach to caring for patients with more timely communication between care teams, which again leads to greater continuity and better outcomes. And ultimately, maybe the most important reason, it reduces client wait times to days instead of weeks. So it allows your clients to get the care that they need when they need it. Genoa Healthcare recently co-authored a peer-reviewed study to measure the impact of telepsychiatry. The study was published in the APA's Journal of Rural Mental Health and demonstrated the impact that telepsych can have on increasing access to mental health care. In the study, we looked at data from 242 Medicaid patients being treated in community mental health centers in rural Missouri. The results found that patients that received a combination of care, so both in-person visits and telepsych appointments, had improved timeliness of care and increased number of total outpatient encounters compared with those who received in-person visits only. Specifically, the study found that patients in rural communities who had access to telepsychiatry were seen 8 days faster and were 34% more likely to be seen once per month, ultimately finding that a hybrid care, so both telepsych and in-person visits, might be more effective than in-person visits alone. I didn't create a slide in the deck on this, but I'd be remiss if I didn't mention the provider incentives as well. We know that telepsychiatry can be effective for clinics and patients, but we also want it to be a rewarding experience for our providers. In Genoa's experience, psychiatrists and APRNs enjoy this modality of care for a few reasons: the flexible hours, the ability to work from home, and the option to earn some incremental revenue while also working a full-time gig. Some providers start small and continue to add hours over time as they see alignment with the clinics they're working at, and others focus on full-time right from the start. Most importantly, though, telepsychiatry allows providers to be mission-driven in their practice. The SPMI and Medicaid communities can be a complex and hard-to-reach population, but it's also why many providers got into the field in the first place. So at Genoa, we're really proud that telepsychiatry enables providers to tap into that passion and that skill that brought them here in the first place. While the study I mentioned focused specifically on rural Missouri and community mental health centers, telepsychiatry has the potential to reach behavioral health clients across care systems. So this means FQHCs, managed care organizations, assertive community treatment programs, and MAT programs. I'll dive deeper into a few of these in a minute, but I just wanted to use this as an opportunity for a quick poll. I'm wondering how organizations feel about their access to psychiatric treatment. So momentarily, you should see a poll pop up on your screen. And there's 4 options in terms of how you feel about access to psychiatric treatment at your organization. So we'll give a few minutes so that everyone can find that poll and share their thoughts, and then we'll read the results out loud. Okay, we'll give about 30 more seconds, sorry, not minutes. Okay, perfect. So thank you to all who voted. It looks like about 50% of attendees said they have insufficient access with an immediate need to expand, followed closely by insufficient access but we're making do. And then the third tier that we're seeing is adequate access with a deep pipeline. So those organizations are lucky. They have providers that align on their needs, and that's great. For those who are looking to expand and looking for additional providers, you come to the right place. And my words to you are to just be proactive in thinking what your exact need is, where is the greatest need, is it with a CNA, is it with your adults, and then working to identify what that exact opportunity is to find care for your community. So again, telepsychiatry is a great resource for increasing access and bringing providers to your community. Okay, so back to the areas where telepsychiatry can be used. One that I thought was important to bring to the conversation is assertive community treatment, also known as ACT. So ACT is an evidence-based practice that provides highly individualized psychiatric services to those with severe and persistent mental illnesses. The practice was formed in the 1970s, and brings together counselors, psychiatrists, RNs, and case managers to help those with mental health conditions. The goal of the program is really to improve outcomes for those who are most at risk of homelessness, psychiatric crisis and hospitalization, and involvement in the criminal justice system. So this means reducing hospitalization, lowering debilitating symptoms of mental illness, and really helping relieve the burden of family members who ultimately provide the care. There are also benefits for clinics, so community mental health centers, federally qualified health centers that are leveraging these programs. ACT is said to reduce staff burnout and increase job satisfaction. It also suggests cost effectiveness by managing hospitalization rates. There are a shortage of providers, which we know, which makes it challenging for ACT provider teams to come together regularly, but that's another area where telepsychiatry can help. We're working on a few ACT programs throughout the country. Right now, we don't have any in New Mexico, but I know there's been some interest expressed from organizations throughout the state, so it's definitely something that we're looking to put together and leverage with interested parties. Here I've highlighted a clinic-based ACT program from Illinois, where our psychiatrist has a 1-hour daily meeting with the ACT team to discuss cases for the day, to kind of make that game plan. And then the patients come into the office and the provider sees them like a normal telepsychiatry workflow, clinic-based. That said, we know that many of the ACT teams go out into the community, so we can also accommodate home-based programs. So this means the case management team will visit a client at home, bringing along a laptop or an iPad, which will allow the psychiatrist to see clients in their home environment and really get a feel for those additional factors that help them best treat the client. In this model, the home must be an eligible originating site. In New Mexico, there aren't any originating site restrictions in respect to telemedicine services, so that actually makes this a viable option for organizations that are looking into home-based ACT programs. Another emerging use for telepsychiatry is medication-assisted treatment, or MAT, M-A-T. MAT is the use of medications in conjunction with counseling and behavioral health therapies to treat substance use disorders and prevent opioid overdose. This treatment approach has been shown to improve patient survival, increase retention in treatment, decrease criminal activity, help patients to hold down a steady job and stay employed, but the ultimate goal is full recovery. In New Mexico, to prescribe medication via telehealth, a prescribing clinician must obtain informed consent, obtain a medical history, and generate a medical record. On the provider side, physicians must take and pass an 8-hour course, as well as meet a few other qualifications to become eligible to apply for a special waiver, so a Data 2000 waiver, which allows them to treat addiction with medications. APRNs have a little bit more to go through. They have a 24-hour in-person course, but they are able to perform this service as well. So to date, Genoa Healthcare has worked on several telemat programs with CMHCs and psychiatrists in our community. We're currently operating one at Hidalgo Medical Services, which Dr. Bowen might touch on later. But throughout our experience building and optimizing programs, we've identified a few key elements that typically lead to more successful programs for telepsychiatry. So the first is flexibility. This means flexibility around workflow modifications, program processes, and close and frequent monitoring of patients. MAT is tailored to meet each patient's individual needs, so it's important for there to be flexibility in that process among the care team. That leads into the second element, which is a collaborative nature. Telemat physicians and APRNs, they're part of a large clinical team. So even though they're remote, they're an integral part of the team on site at the office. So that makes it critical for telepsychiatrists to be proactive and communicate effectively and often when connecting with the rest of their care team to ultimately treat the client. When creating a telemat program, we encourage clinics and providers to discuss prescribing philosophy, appointment times, and workflows to ultimately come to a conclusion that everyone's comfortable with. So back in 2013, New Mexico enacted its initial telehealth bill. It was then amended earlier this year in April of 2019 to reflect coverage and payment parity. So what this means is that health plans in New Mexico are required to reimburse on the same basis and at least the same rate for telehealth services as they would be in-person consultations. So that's for reimbursement. The same goes for coverage. So any service that is covered in person must be covered via telemedicine as well, which is a major victory for telemedicine because not all states have that luxury. How does this help clinics and clients? So again, it greatly enables access by having coverage and payment parity, and it provides clarity to both patients and providers about what's allowed and what will be covered. Okay, so before I introduce again Dr. Bowen and he gets started on his experience with Hidalgo Medical Services, I just want to remind everyone that they are allowed to submit questions with the Q&A button at the bottom of the screen. So we will be having a 10-minute Q&A at the end of the session. So if anything that I've said has inspired some questions or there's something that's been on your mind, please feel free to submit using the Q&A button and we'll be sure to address them at the end. With that, I want to again introduce Dr. Neil Bowen, who will share his experience with telepsychiatry at Hidalgo Medical Services.
Thank you so much, Alex and Lauren, for the introduction. Good morning, everyone. And I realize it's not morning for everybody necessarily, but here in the mountains of Southwest New Mexico, it's still the morning. So I'm honored to be here and pleased to talk about the things that we've learned about using telehealth. I'll describe Hidalgo Medical Services a bit more on the next slide, but I just wanted to let you know, I'm going to talk just briefly about terminology because the telehealth field I've discovered both in writing and in conversations with people around the country and here in New Mexico is plagued a little bit by terminology which can be confusing to people. And then I'll spend most of the time talking about what HMS has learned and how we learned it, which you can hear in part of that how we learn from mistakes. So let's go forward, please. Thank you. Next slide. Yeah. Thank you. So the points I was going to make is that I prefer to use the term telehealth as a global term. We offer actually an array of services via telehealth. And telepsychiatry is one of those services. And it's not just psychiatry. We do provide services by psychiatric mental health nurse practitioners. And historically, we've also had prescribing psychologists, not via telehealth, but in person, because New Mexico was actually the first state where we allowed psychologists to prescribe once they get a postdoctorate master's in psychopharmacology. And the reason is because there is that enormous shortage of psychiatrists that Alex referred to before in New Mexico. And I'll just say, as an administrator, I'm also a psychologist and I have that training, but I'll say as an administrator, psychiatrists are also extraordinarily expensive. We have had psychiatrists on staff, and typically they come out of residency and step into HMS as the highest paid employee of the agency. And that makes it difficult to be sustainable when you're carrying them on staff. Telemental health is a term that we've used because we also provide psychotherapy and counseling via telehealth within our system of clinics. And then the final thing I wanted to point out, we also provide medication-assisted therapy, and I'll spend a little bit of time talking about that, of course. But that origination versus distant site distinction is one that is not immediately intuitive. But the easy way to remember it is the origination site is where the patient sits, wherever they're sitting. And then the distant site is where the provider is. And that might be, in a different clinic within your own system, or it may be, in a different state. I was surprised not too long ago, a few months ago, to learn that the very first application of telehealth actually occurred in the 1960s in Boston, because it took so long to go from a specialty clinic to a hospital that needed that specialty services, that they set up a television studio to provide it. So it's not necessarily extremely distant, but time is important. I wanted to add one thing to Alex's comment about in New Mexico, there's not an origination distinction or an origination limitation in terms of being able to bill for services. And that really is an important step forward. And that's on the Medicaid side, so the state managed side. And they've also applied that to private payers in New Mexico. And that's a very good thing. And it means that you could technically provide services to a patient sitting in their home who has difficulty getting out, and you would still be able to be paid for those services. A difference from telephone services, for example, in New Mexico. But Medicare has not made that adjustment. So Medicare patients still need to go into a clinic in order to benefit from telehealth services in New Mexico. We can't reach them and be paid for it in their homes. So next slide, please. So let me tell you a little bit about Hidalgo Medical Services, because solutions tend to be local solutions, even when they're based on national trends or state or regional trends. So Hidalgo Medical Services, we're a federally qualified health clinic for our service area, which is a 2-county area in the very southwest corner of New Mexico. So it's Hidalgo County and Grant County. If you put those 2 counties together in terms of geography, that's larger than Connecticut and Rhode Island put together. And we have a population of a little under 34,000 in those 2 counties combined. So it's very large. It's actually most of our service area is classified as frontier rather than rural, and then the rest is rural, of course. And the rural area is the area around Silver City in Grant County. We are in the mountains, a mountainous area of the southwest corner of New Mexico, with a population which is split about 49%, various white cultures and various Latino cultures. And then the remaining 2% is divided, between an array of other folks. Unlike most of New Mexico, we have less than 0.5% Native American population here. Because of our rural and frontier area, we have 19 locations spread through that area in an effort to make sure that almost everyone in our 2-county area is within 30 minutes of primary care, primary behavioral health and behavioral health care. We also provide full service dental treatments and family support services, which address the social determinants of health. In the behavioral health department, about 4 years ago, we also became the community mental health clinic for our service area because of a history that I won't go into right now about New Mexico having to do with putting a lot of behavioral health providers out of business through a Medicaid audit. And so we stepped in and became that community mental health clinic for our service area. So we're both. And part of the reason I underline that is because there are actually competing regulations that are sometimes in direct conflict with each other for FQHCs and CMHCs. So for example, as a CMHC, we should be able to bill for telepsychiatry services to everyone that we serve. But actually, as an FQHC, if a Medicare patient is in the origination site, we cannot bill for the service. We can only bill the connection fee, which of course is far inferior to the cost of the providers. We provide those services in any case in order to provide equitable services to everyone, regardless of ability to pay. But that is a restriction which impacts FQHCs differentially in New Mexico and across the country, because that's a CMS regulation that's based in legislation. So we need a change from the federal Congress in order to remedy that. I was glad to hear Alex mention that the VA has been providing telehealth for 20 years. That's where I was 20 years ago, was in the VA, and I was very aware of that. So when I came to Hidalgo Medical Services in 2005, and we hired a psychiatrist pretty quickly after I got here, and then he moved, he was following his lifelong dream of being a psychiatrist for the US State Department. He's actually in South Africa right now. But as he was preparing for that, he left our service area and continued to provide services. So that's that telepsychiatry internally. In 2012, we set up an internal system to be able to continue to use his services because he was very difficult to replace. And then when that became, of course, we knew that was going away. So we explored using telehealth services through the Department of Psychiatry at the University of New Mexico. And the University of New Mexico has a very robust Department of Psychiatry and training program. And already at that time was offering Project ECHO, which was the ability to provide specialty consultation services to to remote and rural and frontier clinics throughout New Mexico. So they weren't necessarily providing direct services to patients, but consultation to providers, and we participated in quite a few of those projects. So when I talked to them about having a contracting with them to provide psychiatric services to us via telehealth, we moved in that direction and used it for a period of time. And I have to say we had splendid providers from them, but one of the things which led us to go a different direction was that the psychiatrists at the University of New Mexico very understandably operated on an academic calendar. And unfortunately, our patients don't live on an academic calendar. And because of, some regulatory things I'm going to talk about in a little bit, including privileging and credentialing, when they would take off for 2.5 months for the summer and say, well, you can have backup coverage from this person, I don't think they fully understood the financial implications for us of that, because we couldn't get paid for those people who had provided backup coverage. So that left us very open to other possibilities. And we actually contracted with One Doc Way, which was a telepsychiatry company, which was then later purchased by Genoa, which became Genoa Healthcare. So we've been with them for quite a number of years, and among the advantages of contracting with a private provider like Genoa is that the providers understand community mental health and community healthcare quite well, and Genoa understands it quite well. So we have not had that disruption in services that we had when we went to the University of New Mexico. So that's one of the advantages. Another advantage that we learned about very quickly was the responsiveness of Genoa to our particular needs, and of the match of provider to our population. So we've been through quite a few different providers. I think quite a few, probably 5 or 6 through the years with them. And we currently contract with them for 3 providers, not all of them full-time. Genoa has been fabulous in working with us on meeting our needs, not necessarily the needs of the individual providers. So we have a psychiatrist that comes in from, who sees adults from Florida. We have a psychiatric mental health nurse practitioner who comes in from Florida as well, who works with adults and provides that medication-assisted treatment for us, among other things. And then, and we also have another psychiatric mental health practitioner through them that specializes in children and adolescents, which is quite a precious resource, and they all are very busy with us. I wanted to point out that that psychiatrist I mentioned before already provided Suboxone medication-assisted treatment in 2011 to our patients. We were the only site in New Mexico outside of what's called the I-25 corridor. So if you think of, Albuquerque and Santa Fe, they both sit on I-25, and then so does Las Cruces, the largest town in the south of New Mexico. But we were the only outside of that area that provided, only agency that provided it then. And we've provided it pretty continuously through the years. Although our service area, we got down to one X-waivered Suboxone provider about 1.5 years ago. And then we became participants in a state-funded, which many of you may be familiar with, grant to address the opiate crisis in the state, an SRT grant. And currently we have 7 waivered providers in our system. Most of them are in our larger clinics, and I'm counting among those the 2 Genoa providers who are also waivered. So, so that's been a very important response to our need to expand our services to respond to the opiate crisis. And I want to give you, I don't have a slide on this in this deck, but I wanted to give you some reason about why that was so important to us. So many of you will be aware that recently people have been looking at alcohol-related deaths, drug overdose deaths, and suicide as kind of a slash line, 3 key indicators of well-being of populations. And New Mexico is unfortunately in line to become the most impacted state in the country when you combine those 3. And within New Mexico, Grant and Hidalgo counties, our service area, have higher rates of alcohol-related deaths than New Mexico, about 3 times the rate in the United States. We have about double the New Mexico rate for drug overdose deaths and about twice as many as in the United States. And for suicide, New Mexico is part of the Rocky Mountain suicide cluster that many of you will be familiar with. And within New Mexico, so the background rate in the United States is 14 completed suicides per 100,000 of population now. That's up over the last couple of years from 12. In New Mexico, the background rate is about 21.9 per 100,000. And in Hidalgo County, it's 64.8 per 100,000. So we are at an epicenter for the suicide crisis. And now I have to admit that, very small numbers can make incidence rates change dramatically according to a relatively few events. But in any case, that's been a consistent area of Hidalgo and Grant County have had higher than normal rates of completed suicide. And what we know because of our work is that a lot of that is related to substance use and hopelessness, of course. So we wanted to have a very robust response to that situation. So let's go forward to the next slide, please. So considerations. So federal legislation and regulation, it trumps in some sense the state legislation. So even though New Mexico has made very positive strides in the direction of expanding the ability to use telehealth appropriately, some of the federal legislation we still have to pay attention to. So, and that has to do with Centers for Medicaid and Medicare Services, CMS regulations, and some has to do with legislation. So for example, many of you will have been aware of the Ryan Haight Online Pharmacy Act, which was a way of trying to make sure that, specious online pharmacies providing all kinds of drugs to people were not going to be able to take advantage of the very legitimate need of telehealth services. So it required the establishment of a patient and provider relationship before a prescription could be made, and that had been interpreted and in fact understood to be an in-person exam was required. One of the exceptions for that is when the origination site is within a medical clinic. So the physical exam portion of that requirement does not necessarily have to be performed by the remote provider. As you could hear from when I talked about where our providers are in Florida, that would be an impossibility. So our providers, our medical providers can provide that physical exam function for them, and then they can move forward confidently as they make a treatment plan that the physical exam portion is very well taken care of. So we were never prohibited from using that within HMS by the Ryan Haight Act because of our being a federally qualified health clinic. Last year, the support legislation, which is, I'm sorry, I'm blanking on the exact reason. That's an acronym. Support was passed by Congress and signed by President Trump, which instructs CMS or HRSA to create regulations which make it easier for remote providers to be able to provide medication-assisted therapy. It also, those acts, in addition to state acts, do require informed consent for telehealth, a specific informed consent for telehealth. And looking for that led us, and I want to give you a resource. There's a center called the Center for Connected Health Policy, that's cchpca.org, which is HRSA designated Center of Excellence for information about policy and legislation affecting all kinds of remote healthcare. So that includes real-time telehealth, which is, end-to-end people talking in real time to one another, store and forward kind of systems where a patient might record a message or information for a provider who might pick it up several hours later and then record a response and send back to the patient, which is not permitted for some applications, but it's a type of telehealth which exists. So the support is designed to increase the ability for all kinds of clinics to meet the needs of their patients. It also removes some of the geographic restrictions. Frontier and rural environments were privileged in the telehealth arena for many years because it was presumed that it would be more useful there than in an urban environment. And because of accumulating evidence that that's not necessarily the case, that restriction is gradually being dismantled. Alex mentioned that in New Mexico, telehealth is required to be paid as face-to-face. Again, that's for Medicaid patients and for private payers. And we do that, of course, as a federally qualified health clinic. Part of our mission is to provide services regardless of ability to pay. So we do that also for our self-pay and sliding fee patients. Again, we run into a Medicare restriction, which makes it more complex. I wanted to point out that prior to using a contracted telehealth provider that may be in a different state, there's still the requirement that they be licensed in the state where the patient is sitting as well as in the state where they're sitting. So they need to carry multiple licenses. There is movement towards interstate compacts for licensure. That's happening for nurses. That's very advanced. It's happened in 9 states for psychologists, there is exploration of expanding it. And there are some states which have legislation which will recognize the license of a provider from one state within their state if they're operating by telehealth. And then they have to get a telehealth license in the state where the patient is, which is less expensive and less cumbersome than getting multiple licensures. So it's important that you be aware of whatever the regulations are and legislation is in your state as you explore this. And then credentialing and privileging must also be accomplished even for remote providers. For all federally qualified health clinics, for example, that we benefit from the Federal Tort Claims Act as malpractice provision. So we must complete credentialing for all of the payers of that individual provider, and that can only start once they have the appropriate license in our state in New Mexico, and then privilege them within our system and engage in peer review processes and that sort of thing. So building in a lead time is really important because you might say, oh, let me contract, and whoever you contract with might say, we have a provider who could start in 2 weeks. And that may or may not be possible depending on your reality, but building in time and cooperation to get that credentialing and privileging done is very important. Another thing that we discovered is that even though the XDEA number, which is the special license which permits the prescribing of Suboxone to people who are suffering from opioid use disorder, even though that's a national number, which is associated with the license of the provider who completes that special training, it turns out that if you have licenses in multiple states, you must associate that X number with your license in each state individually. And that can be a fairly surprising and I'll just use the word bureaucratic process, which can take time as well. And then finally, and I know I'm starting to push the limit on time, but I wanted to talk a little bit about workflows, which are very important. One thing we've discovered through the years with our remote prescribers is that it helps them a lot, and it helps us a lot to work hard to help them feel and see that they're part of a treatment team, that they're not a one-person shop that just is responsible for taking care of all the needs of their patients. So we've intentionally placed the telehealth rooms on the hallways with our mental health therapists, for example. So our mental health therapists do drop in and visit with our remote telehealth providers to talk about individual patients, to coordinate care well. We also have a very robust care coordination department within the mental health department. We have 2 different care coordination projects going that basically can provide intensive care coordination for anyone who has a mental health, including substance use disorder problem, and have a co-occurring chronic medical condition or are at risk for a chronic medical condition, which many of you will realize immediately means everybody who is either has a chronic medical condition or is at risk of it. So developing workflows where there is interactive communication between the remote providers and the on-site different kinds of providers we have is really critical to the full success of this model. I will say we also have Genoa pharmacies at our 2 main clinics, one in Hidalgo County and one in Grant County, and their pharmacists have been really wonderful at helping ensure that our patients get the substances, the drugs that are prescribed for them, including Suboxone, and get the appropriate education for that. They've also participated in treatment team huddles for some of our most complex patients, and that's been extraordinarily valuable. It's not a requirement for telehealth, but it certainly does contribute to success. You'll note that I put there the critical role of medical assistants. We have quite a staff of medical assistants that like many locations, we hire for attitude and then train for skills and then reward them as they move up and increase their skill sets. We have specific medical assistants for mental health that have been really stupendous, I'll say, in working closely with the remote providers to build a working relationship. Those medical assistants are responsible for making sure that the physical exam requirement has been taken care of, and in the silence in the federal legislation about that physical exam as to how recent it has to be, we established 30 days as the measure. So the medical assistants make sure that has happened and document it and make sure that gets to the remote providers. They also provide the urine drug screens and other kinds of labs for the providers, make sure that information is assigned to the provider in our electronic health record. And by the way, that's been something that we found has worked much critically well, is giving the remote providers access to our electronic health record directly so that they document their encounters directly, and then all of our billing is associated with that, of course. And also are aware of what else is going on. So there's the medication reconciliations are done by our MAs as well. Some of the checking the PMP, the pharmacy tracking of people's use of controlled substances, that's not done necessarily by the medical assistants, although they do. That's within our workflow is handled by some of those care coordinators that I talked about. And then that ability to prescribe electronically, has been difficulty historically with prescribing controlled substances electronically. They were required to be on paper for a long time. We found through our electronic health record provider, the eClinicalWorks, that we could send an electronic fob to those remote providers, which was bound to them. So a way of assuring that the person making the prescription is actually the waivered provider. Which makes for the possibility of sending those electronic prescriptions directly to the pharmacies, and that being honored, and that's working quite well. So those are the basic things about the workflow that I wanted to point out, and I think that takes us to questions, unless I'm mistaken. So let's.
Thank you so much, Dr. Bowen. Yes, so we will now, that information was really valuable for organizations considering telepsychiatry or looking to grow their programs in different care settings, so thank you again. We received some questions which we'll now read out for Dr. Bowen and Alex to answer. The first question is for Dr. Bowen, I believe. Just to clarify, did you say that the parity law for reimbursement requires the patient to be in a health center and that it doesn't apply if the patient is at home?
That's a great question, and I didn't intend to apply that it's the parity law which requires that. That's actually a CMS regulation for federally qualified health clinics. So it may be a restriction on FQHCs that doesn't apply to community mental health clinics that are authorized, at least in New Mexico, to provide services directly into the home.
Thank you very much. The next question is, I am curious if any potential exists for the VA to contract with a company as Genoa Healthcare to increase veterans' access to care. So that might be good for you, Alex.
Sure, I can take care of that one. So many of you might know that Genoa Healthcare actually became part of United Health Group, specifically Optum RX, back in the fall. So now that Genoa is part of Optum, we're working with Optum Serve, which is managing the Community Care Network, the CCN, of outpatient clinics for the VA. So the CCN has several features with the goal to improve care coordination and make it easier for community providers and VA staff to deliver care to veterans. So we're currently in the planning stages of exploring how we can expand access to veterans seeking care in non-VA settings. So again, we're still in the planning stages, but we're happy to reach out with more information on that as we continue to see how we can work together to best treat the VA with their behavioral and healthcare needs.
Great, thank you. The next question is, what is the difference between doing telepsychiatry with my own providers or working with a telepsychiatry vendor?
Yeah, that's another great question. And if you already have providers that are interested in doing telepsychiatry, then you're kind of one step ahead. But I'd say most clinics, so CMHCs, FQHCs, they come to us because they don't have access to providers. And specifically, they don't have providers that understand community mental health centers. They might not have providers that align on their prescribing philosophies or appointment times, all which are necessary to ensure quality of care. So again, they might not have access to the right providers because telepsychiatry is more than about putting a provider in a chair. It's about workflows and operational management. And over the past 7 years, Genoa has developed best practices and workflows to ensure that continuity of care. We have huddles so that our remote providers feel part of the care team, and that despite the fact that the provider is in another location, they all work together to best treat the patients. Another reason that it's important to work with a vendor, if it's an option for you, is because we have the regulatory expertise that's essential to creating a compliant program. So as Dr. Bowen mentioned before, the rules for Medicaid and private payers may differ from Medicare, and all of that is really essential information for making sure that your program is effective and complies with the regulations. And then lastly, the technology is a crucial part of an effective practice. You need to make sure that you're using a HIPAA compliant program. You want to understand how the provider can document into your EMR so that note-taking is precise and accurate. You want to make sure that there's the proper protocols in place for e-prescribing. So there's a lot of various factors to be mindful of when making sure that a program is clinically and financially sustainable. And vendors such as Genoa and others, that's kind of what their job is, and that's what the expertise is. So that's the role we can play.
And if I could, I'd just add in, we actually have a blended system. We do have those 3 providers from Genoa that I mentioned. We also have a psychiatric mental health nurse practitioner who was here in New Mexico with us for a period of time, and then for family reasons moved back to Portland, Oregon. And she continues to provide services 2 days a week by telehealth to us. And Alex is exactly right. It's more than just having someone sitting in a chair, but she's actually doing her doctorate in nursing, studying telehealth. So she's been an amazing resource for us as well. And that telemental health piece that I talked about, where we provide psychotherapy to some of our remote one provider clinics, we use our internal counselors and social workers and psychologists to provide that service.
That's good perspective. Thank you. One more question for you, Dr. Bowen. Do APRNs prescribe scheduled medications in New Mexico?
Yes, they do. APRNs are considered independent practitioners in New Mexico. They're not required to be supervised by a physician of any kind. So yes, they do.
Great. Okay, this is a question I think for Alex. What are some potential barriers to a successful program?
Sure. So I think there are a few layers to that question. As we've heard throughout the past hour, Medicaid, Medicare, private payer, there are federal regulations and state regulations which can prevent an organization from successfully employing telepsychiatry for their organization. So it's really important to make sure that you understand what's allowed and what's not allowed in your state, so that you're following those guidelines, because if it's not allowed, that's obviously a major barrier. Other than that, I'd say it's really important to properly educate your team on the benefits of telepsychiatry. So this means connecting with your organization to review the numbers with your CFO, so see if it's financially sustainable. I would talk to your medical director and see how they can incorporate this into the care team. Connect with your clinical staff to see if they're comfortable working with a teleprovider, and kind of work through best practices to see how they can communicate. And then ultimately education for the patients. A lot of us now are just used to being on smartphones and computers because it's 2019 and that's our life. But you want to provide patients with the option and the education so that they feel comfortable connecting with their provider remotely.
Great. One last question, I believe. Do you only hire APRNs that are in independent practice states, or how do you handle supervision/collaboration?
Sure. So many states, APRNs can practice independently, but for others, they do require that collaborating physician. So we can work with organizations. We've had situations where we would find both an APRN and a collaborating physician for the organization, or often we'll see that the medical director or another physician on site will serve as that collaborator.
Great. Okay, one last question just came in, which is, I just graduated from medical school. Have you or your organization had any experiences with using telepsychiatry in medical education? If so, what can you share?
So I'll step in on that. One of the things I didn't mention about HMS is we actually have a family medicine residency program within our agency. So those folks do get lots of exposure to our telepsychiatry as part of their rotations through behavioral health. And so that's the main way that they get experience with that. They also get some exposure to the telehealth aspect with our counselors, providing it to those remote clinics. And we also use it's not telepsychiatry, but a form of telehealth to provide some of the didactics. There's a rural collaborative of specifically rural family medicine residency programs, and I've provided training for people in 5 states, for example, and our residents quite regularly participate in that. So.
Great, thank you so much. Those were all very interesting questions, and unless anything comes in last minute, I think we're getting close to time. We'd like to thank you, Dr. Bowen, and thank you to all the attendees here for joining us today, and most importantly, continuing to do the important work to increase access to behavioral health care for underserved patients. We will be sending a recording and slides of this webinar early next week via email. Please, in the meantime, feel free to reach out to us or Dr. Bowen with any questions. We will send all of our contact information. And with that, we hope everyone has a great day, and thank you again for joining.
Great, thank you, Lauren, and thank you, Dr. Bowen.
So much.
Thank you both so much. That was fun.
Bye.
All right, bye.